Welcome to the Health Impact 2020 session on innovation. These days, in the post-COVID world, innovation has seemed to get even faster than we have ever seen it before, even in modern times with all the AI and RPA and telemedicine and everything that we saw before the COVID pandemic reared its ugly head. What I've heard from a number of innovators, and we have a lot of innovation folks in the Health Impact audience, and of course we have some excellent panelists, which I'll introduce in a second. We've been hearing this problem that what used to take 2 years to do in healthcare now has to be done in 2 weeks or 4 weeks or 6 weeks. And so what we're seeing is innovation in healthcare can absolutely happen quickly. The question is it the right thing? Are we doing it the right way? Are we getting the benefits that we need from it for patients and their caregivers? Those are the kind of things that we're going to really talk about today. So with that, I'm going to introduce my panel here, starting with Ashma. Ashma, tell us a little bit about yourself, and then we'll have Rasu and Chris introduce themselves as well.
Thank you so much, and honored to be here in this virtual fashion. I lead healthcare strategy for the industry and lead building of transformative solutions for Google Cloud. It's been quite a trying times for all of us, and thank you for doing this and bringing us all together here.
Also a pleasure to be here virtually. This is the new normal, or the next normal as we're calling it. Well, I'm Rasu Shrestha. I'm a radiologist by background. I'm the Chief Strategy and Transformation Officer here at Atrium Health. Atrium is a fairly large multi-state integrated delivery network. We're about 50 hospitals, 70,000 teammates, headquartered out of Charlotte here in North Carolina. And we have a presence in North Carolina, South Carolina, and Georgia, which if you think about COVID and the way that it's really playing out, things are really continuing to heat up here. So that's what I do, and where I come from really is the perspective of how do we really leverage innovation as a strategic imperative to transform health systems and use this opportunity to really make meaningful change happen. So looking forward to the conversation ahead. Thank you, Shadi.
My name is Chris Waugh, and I'm the Chief Design and Innovation Officer at Sutter Health, also a large integrated system here in Northern California, where we're treating the elite of Silicon Valley all the way to some of the poorest zip codes in Northern California. So we like to think that we're a good representation of US health overall and have about 10,000 physicians and 55,000 employees. So this has been a fascinating time. We definitely hate that it's built on the backs of a pandemic, but it has radically accelerated the innovation agenda. So excited about this conversation today, and thanks for pulling us together.
Sure. Yeah. Maybe let's just start with that. So the radical acceleration, as you've said, is something that we're all seeing. But what does that happen to do with the culture of innovation? So, for example, if you were not innovative before, do you think that now the change in dynamics of how fast the pandemic is progressing in different ways changes your culture and makes you more innovative because you have no choice? Or if you were not innovative before, things just get worse after the pandemic? What are you guys seeing? And maybe I'd love, since you said it, radical acceleration, Chris, tell us a little bit about that, and we'll have Rasu chime in.
I think pre-pandemic, we had pockets, really hot pockets of innovation happening in the system. And during the pandemic, we saw the whole system turn and crave new tools. So the obvious one would be virtual care. And we saw a few things happen. One, we saw regulatory changes that allowed some of that care that wasn't reimbursed to be reimbursed. We saw a pull from patients that normally might not be requesting that type of care. And we had a physician base that wanted it too. So all of a sudden it was this trifecta of everyone wanting the same thing. From a design perspective, we look at it through the lens of human factors, and we saw things like physicians say, I've seen this patient for a very long time. He's in a wheelchair and I thought he was doing just fine, but now I see the virtual visit and his wife was in the background and she said he's not doing well at all. And so I think those things are really obvious, but the innovation team has seen opportunities in things like lactation support. Thinking about virtual visit and lactation support is really different. It's not just a video visit, and so really thinking through those human factors has been, not only is the technology ready and the pull's there, but then how do you overlay new modes of delivering care as if this was the first time you'd done it? And we like that clean slate feel. So not just replicating what you were doing in person, but how do you use this opportunity as the first foray into fundamental rethinks of the care? So that's what excites us. The change is a little tiring. I think the system is, you can feel a little the change fatigue, but I will say that, we've just seen tremendous adoption of AI, virtual visit, because of so many factors all lining up at the same time due to COVID.
Yeah, and we heard, of course, for years that if only reimbursement could change, if only HIPAA rules were relaxed a little, then the following would happen. And I think that experiment has borne out in real life. Rasu, jump in a little bit, talk about two things. One is the fact that these changes occurred, especially on the reimbursement and relaxation of the HIPAA rules. How fast were you guys able to accommodate at Atrium, and have the dollars actually matched the reimbursement requests? Like, we're hearing a lot of smaller and middle-sized healthcare providers be able to send their claim, but it's not like the money is rolling in. Are you hearing the same thing, or are you seeing some differences there?
So really interesting discussion here. I think one of the most remarkable differences pre-COVID and sort of this next normal that we're living in right now is that innovation was this cool thing. It was this department, it was this division, it was this group, on the side that did some really amazing, cool things, design thinking, sticky notes, all of the things that we're all disciplined scholars of. What's different now is that innovation is a strategic imperative. Right? You cannot afford not to be innovative. It's not just this cool thing on the side. It is the thing that you do. It is what gets you continuing to actually make an impact in whether it's the care that you're providing, whether it's the interactions that you're having with your communities and with the populations that you're trying to treat. What's really interesting is COVID-19 has, I think in many ways, really accentuated the fault lines that already existed in healthcare, right? Those fault lines already existed. I mean, in Charlotte, in the Southeast here, North, South Carolina, Georgia, one of the things that's really startling, I've been here a little over a year and a half now, and one of the things that's really startling is the difference between the haves and the have-nots. The disparity could not be more stark. And when you look outside, we see, amazingly tall skyscrapers, Bank of America, all of these banks. Charlotte is the second largest financial hub in the country after New York, but it's also number 50 in the top 50 metropolitan cities when it comes to upward mobility, meaning if you're born poor, chances are you'll stay poor. I think, if anything, COVID-19, the economic implications of COVID-19, and then the racial inequalities and the tensions that have arisen, they're all tied together. And those three punches in the gut that we've seen in the last 4 months, I think really shine a light onto both the challenge as well as the opportunities at hand, right? The challenge of, all right, how do you fix the gap between the haves and the have-nots? And the opportunity there is really, let's tie innovation back into that strategic imperative. Let's make sure that we're able to, take some of the early wins. You mentioned, some reform, whether it's around HIPAA or whether it's around potentially even telemedicine, virtual. There's parity now that I think is still temporary. I'm not sure that it's permanent just yet, payment parity and such. But it needs to be permanent, right? It needs for this to be tightly embedded into the very essence of what we do. Telemedicine shouldn't just be a Band-Aid solution that came to the rescue of COVID-19. It's not a Band-Aid solution. It's a fundamental foundation of care redesign and care transformation. So I think if we think about it from that perspective, where innovation is tightly coupled to your strategic imperative, whether you're a large health system like us or a smaller health system or a small private practice sitting somewhere, that's the way to really make progress moving forward.
Yeah, so I love what Chris just said about the rethink, or the idea that, imagine you were doing care for the first time. What, Rasu, would that look like for an Atrium, the size of Atrium? I mean, you guys are a huge institution. does that shift culturally what you're doing? And I'd love for Chris to jump in and say what couple of examples do you have from there? And then Ashima, I want from your perspective on the Google side, you guys see things across these industries. I would love to see what that rethink has looked like. So Rasu, tell us, any rethinking has occurred there at Atrium?
Yes, definitely. There's been a lot of rethink. In this VUCA environment that we function in, the volatility, the uncertainty, the complexity, the ambiguity. One of the things that we've quickly realized is that we have to rethink the way that we're actually interacting with our patients and our communities and our consumers. So one specific example that I give you is really around our consumer journey. I think for the longest time in healthcare, we've really been focusing on the care element, right? The healthcare, in fact, the sick care element. And one of the things that we'd started to do at Atrium that really has been, I think, accelerated as a result of what we've seen with that trifecta of punches that I mentioned earlier, is the need for us to really think across the consumer journey, the transformative consumer experience that we're talking about and building here at Atrium Health. So it's not just focused on care, which is absolutely important, but it's full circle. It starts with awareness, the consideration, the selection, the care, the advocacy, and then back into awareness. And I think it's that circle around the consumer, around that patient that sits in the middle, in the communities, in the context that they live and work in and play in. That's the element that was missing in many ways in transforming the experience element, not just the transactional elements of healthcare that we've been so focused in on, but the experience element. And so, that's one example of how we're rethinking the care paradigm altogether.
I think I love what Rasu said there around, thinking holistically. And if he mentioned sick care, and I think this is the insight from the innovation team out, is you're your own doctor 99.9% of the time. And so in this world of sort of always on care, for us, the thesis is the care comes to you, you don't come to it. And the innovation teams worked on something we call the tedium score, which just is the time wasted, whether that's driving to an appointment, doing a search, like where's the wasted loops where we could clean that up and reduce the tedium score and get to resolutions really quickly. But really get in a position of empowering and really changing the dynamic between a care team member who's telling you what to do to a many-to-many model. If there's many people around you, what does that look like? And we're starting to see shifts with virtual care where, a physician I talked to recently had a daughter in Hawaii, the patient was in Sacramento, and another member of the family had virtually piped in from Oregon. And it was like, wow, this is a whole new way to empower the patient and their family back to that think from scratch. And so we think the care comes to you. We think that it is continuous and always on in this world. And I can't wait to get to Google, where we look at things like continuous data feeds spinning off the patient's life in their consent, and that being piped back into the care plan and the feedback loop. And we're testing this with things like sleep, et cetera. And then ultimately, it's about making it radically more affordable. We take out two of the most expensive features, which is a physician and a physician's time. Who else is part of the care team on our side? Thinking expansively about that. And any community center can think about that as well. You don't need to be big to think that way. In fact, you may even be more advantaged to think that way. And then think about who's on the care team on their side. And once you start reshuffling the deck chairs on whose team, and then thinking about continuous data flows and feedback loops, this is all brand new, and it shifts radically from sort of interstitial care where we will prop people back up and do a great job of doing that, give them medication, et cetera, and then they go back out in the world and maybe they're successful, maybe they're not, maybe we don't know. And then how do we flip that to knowing loops? How do you know what happened? How do you support the feedback loop and keep a patient going in a successful trajectory? So really excited about that. Always on care, always continuous, more data feeds, and then ultimately radically more affordable. We build some pretty expensive buildings. Do we need those as much as we thought we did? Yes, you need some. We don't think there's a building-less care model, but what's one where the building, it works in harmony with the digital experience, and you only are in that building when you absolutely need to be versus just because it was convenient for us to have you come. So yeah, I'd love to hear the Google perspective as well.
Yeah, so Ashma, obviously, there's nobody who's going to say Google's not already innovative. But as you looked at what Google has been pushing people into the cloud for years, now healthcare has moved to the cloud much, much faster than it was really prepared to do so. From the healthcare point of view, where do you see people making good strides versus mistakes? So are we doing things a little bit faster?
You're absolutely right. In Google, our overall mission is to help connect wealth information and make it accessible and useful. And this mission transcends to healthcare in many, many different areas that we operate in and help our consumers or enterprises in. One thing I have seen from Google Cloud perspective, what we saw, whether we are working with the healthcare or retail or telco in many, many different industries, is our customers and all of us are living in the environment of these constraints. And these constraints help by ensuring focus, they help by ensuring urgency, and in the case of COVID, a higher purpose. So rather than providing like ample resources and freedoms and multi-weeks required for business cases, what we hear from our customers and partners, there's a sense of urgency, there's a sense of purpose, and it's imposing a much tighter deadlines or timelines. So proud to be part of an organization where we're helping all of you of the industry. And let's not forget what is the main center and the nucleus is the common purpose to being helpful, and that's where everyone is kind of rallying behind. And in that scenario, it's not about like telehealth. Yes, telehealth is the thing that we are seeing a lot more focus on. But I also wanted to step back and say it is the innovation culture driven by urgency and a bigger purpose that has completely changed how we operate. And I hope this doesn't end with the pandemic. Right? And it's not just the formula when we're in the moment of global crisis, but on a day-to-day basis, can we take things with a sense of urgency and address them? The other thing that I learned from the pattern perspective that the path forward is not always about building something new from the scratch. Right? We saw that example that Rasu gave. Right? There is telehealth, video visits happen there. But it's also about the agility of of either modern IT or design thinking to combine and connect existing system in a new ways. So that I saw that in many different ways in healthcare. As an example, we work with Cambridge and Alliance. They were using G Suite and they had this meet for internal communication. They completely flipped it on in terms of providing the service from patient to provider communication. So urgency, purpose, but also new ways of leveraging. I think that's what constraints do. That's what tight timelines bring forward is being creative and seeing rather than something from scratch, what can we combine together?
Love that point, Ashma. I think I just have to hop in there. I think that's how are you anchoring this in people and really understanding what the need is. So just to build on that point, when COVID hit, we remember the last meeting I had in person. We drove by the ship that had pulled into the port of Oakland, which was a very symbolic day of shutting things down and bracing ourselves for surge. But we started thinking about the care teams themselves instantly. So what did they need? Well, in order to be great care team members, they needed childcare. In order to protect their families, they needed to quarantine away from their own families. And so we started as an innovation team processing that, and we said, well, Silicon Valley loves to matchmake. There was a startup called Urban Sitter, which was just connecting care providers that could care for children with those people that needed it. And they put our care teams at the top of the need list. And so that was great. We didn't need to innovate that ourselves. That was a partner. Airbnb said, we've got a lot of vacancies. You have people that need to distance themselves. We're going to prioritize healthcare workers through Airbnb. And we've seen now over 800 stays at Airbnbs of people that are self-quarantining. But then to your point around now the creatives, this is the creatives' heyday. So the creatives chimed in and they took it a little further. They said, well, there's a cool company called Outdoorsy and they do Airstream rentals and RVs. And we're seeing these families that they don't want to leave their family, but they want to distance from their family and protect their family. So we started pulling Airstreams into people's backyards, and they would quarantine at a distance but stay home. And so, we didn't see a ton of uptake on that, but still, it's like pushing and pushing. Back to your point, is taking these known things and putting them together. And COVID's just providing a venue to keep trying and then see what sticks. So I love your point. It's excellent.
The imperative for systems like us, and again, this is true for smaller systems, perhaps even more true for smaller systems, is that it's important for us to weed out the signal to noise ratio, right? This is, and a lot of the noise that exists out there are folks, individuals, startup companies, entrepreneurs, investors wanting to help, wanting to step in. And I think it's important for us to really be strategic about the way that we do innovation. And that's part of what we've been doing at Atrium Health, is really tying innovation into the strategy and transformation office, really connecting it with data and analytics, connecting it with even our marketing and communication acumen so that we can look at consumers differently, like the way that I was describing earlier, but also tying it specifically to our strategic direction in terms of where we're going, how we're evolving as a health system, and what it means to actually come out winning. So I'll give you an example of an innovation that we were really focusing in on, that I think we managed to get that signal to noise ratio right. So in the midst of us essentially hunkering down and shutting electives off and such, and getting ready for that surge, one of the things we said was, hey, we've been looking at this point of care ultrasound. So Shahid, I'm a radiologist by background, right? So we've been looking at this point of care ultrasound, and I think this is the right time for us to really pull the trigger on deploying this in the front line. So we went with this point of care ultrasound device that just had the right elements of a number of different things that I've been pushing back on point of care ultrasound for about a decade or so now, right? I wanted for the price point to be just right. I wanted for the price point to be below $2,000. I wanted for the size to be just right. It needed to fit in a pocket, in a white coat. So when you're going out, whether it's in a tent or in the ICU or in the ED, you had it handy. And then thirdly, I wanted to make sure that it was cloud-based and AI-driven. And that's what we did. So we were the first health system to really go live with this point of care ultrasound device from Butterfly. And we deployed dozens of these devices across more than 30 different sites across the Atrium Health organization. And what we were able to see was the ease of use of these devices in the front lines, not just by clinicians, but also by paramedicine staff. So when we're doing the COVID-19 virtual hospitals, where we were actually going out and visiting our patients in the hospital, for patients that didn't need to be in the ICUs, or when they were coming into these pop-up clinics or into the EDs, we had this device that suddenly could help with the triaging. That was really easy to clean, that was able to give that human element to how it is that we were interacting with our patients and with our communities. So an innovation that really rose to the occasion, and now we're looking at what does a broader deployment of this device and this technology really look like, because I think that this is the stethoscope of the future. I think that every medical student, every trainee, every physician will be walking around not just with a stethoscope around their neck or in their white coats, but really a point of care ultrasound device that is driven by cloud and AI, which I think makes us.
I love that. I love that, Rasul. But I go even more humble innovations. Right? For example, you talked about patient triage. When COVID-19 hit, many of our payer provider customers, their call centers were overloaded. They were looking into, could we even reduce the call volume, right? So our AI-based conversational chatbots were deployed in the matter of days, like less than a week. They stood up this basic COVID-19 triage. What are your basic symptom checkers based on CDC guidelines and those templates? There's AI underneath. However, in the clinical setting, it is that very humble innovation to help people who are struggling with getting these answers, getting a self-service conversational AI. And now it speaks 28 different languages, right? When we talk about health access and equity, being able to speak in their language. We talk about telemedicine from take as an example Google Meet. There's a thing called closed captioning. So whatever I'm saying to you, you can read it. So for people, it becomes that technology can help with that reduction of barrier between patient and the provider. I always saw before this technology kind of getting in the way. In COVID-19 and with this pandemic that I'm seeing in all different fields, technology is actually bringing the connection we have. And I know this happy hours virtual will eventually fade away, and we are all getting tired of it. But in the moment of crisis, in our most vulnerable moments or the moments of joy, it has connected us all. And hopefully that will stick. This new ways, the new habits are being formed.
Yeah.
Um,
Yeah, I love that. That just the mindset shift from healthcare system response prior was someone has a symptom, you must need an appointment to our symptom checker has been Ada, using AI through symptom checking. And the thing that inspires us about Ada is the crux of their model was we want to give 1 billion people in the world who will never see a doctor in their lifetime something in their hand to get a sense of directionally what's going on with them. And just being able to complete the sentence. So Ada as a standalone company is interesting, but to complete the sentence is to go from something's wrong with me to check my symptoms to video visit within 20 minutes. That's incredible. And that's just slicing back to the TDM score. In some cases, that's slicing weeks off the prior way of doing it. And so, and having those AI algorithms built for COVID quickly, we saw about 200% increase on utilization of that tool because of the need. People didn't want to come to clinics. I didn't want to go to a clinic either. Who would? And can they quickly get symptom checked, video visit, and then determine it's actually necessary that you come, or here's what you need to do? Is a real breakthrough. So excited about that. And again, using cloud and more AI, it's like it's only going to get better. So this is kind of the crack that let the light in. And I think what we're seeing now, which we're very cognizant of, is this is pandemic care, which is going to be different than post-pandemic virtual care.
I think the new habits are being formed. Like I'll give you an example from the retail industry. Like we all are consumers and we have been forced to break our normal routine. And more than 50% of shoppers had tried a new shopping service for the very first time. I can tell you from personally for me, the curbside pickup is actually time saving. So the pivotal question is, how many of these habits will stick? Exactly. Which of our operational metrics will go back to the historical averages, or is this going to be the new behavior that consumers are going to stick to and will demand this new service? Like the recent telehealth, yes, there's a CMS reimbursement in health policy and that debate, but also from the consumer standpoint, people didn't think they would get the same value going into the clinic versus video. And many of the friends and the industry people that I talk to, they are finding it convenient. Like if you need a prescription, right? So there's new ways and there's new habits and new convenience that pandemic has taught us that what little we need, and in some cases we need more, and you absolutely need to go to the physical facility.
That's right. And I think Rasul will agree that our physicians are finding that they can do far more than they thought they could virtually. And I think that's been very, very promising. So
how about let's talk about the elephant in the room is, how are people going to get paid for all of this, right? So currently there has been a massive drop in primary care, massive drop in surgeries, et cetera, as far as revenue is concerned. And as you start to look at these new models, are people actually getting paid for the telemedicine that they're doing, or are we just hoping and praying that this business model will actually work next year? So any thoughts on the reimbursement and actual payment side?
Yeah, I think the genie is out of the bottle, so to speak. The challenge is, will that genie find its way back home? You know, and that's one of the things that we realized. I think this is across health systems, small, medium, and large. We saw a massive uptick in the use of virtual and telemedicine. You know, as COVID was ramping up, at Atrium Health, we saw a 1,700% increase in those numbers of video visits, et cetera. And what's happened is that those numbers are starting to ramp back down, right, across the board. At Atrium, we're really pushing ahead in terms of incorporating the virtual health capabilities directly into the new care models that we're actually putting in place. So like I said earlier, it's not just a Band-Aid solution, it is a fundamental foundation of care redesign and care transformation. But to your point, the issue is that we're still waiting for that payment parity to be permanent. I think what happened was payers and CMS, they really stepped up their game in the midst of COVID-19, and they promised parity, which is awesome, but it was temporary. And we had this conversation when Secretary Azar came to visit us here at Atrium Health a couple of weeks back. This was his first visit to a large health system, as he was able to at least put his head up and say, all right, let me go out there and speak to health system leaders and visit these systems. And we told him, we thanked him for all of the work that CMS did, even in the weeks as we hunkered down in COVID-19 and provided the parity elements that I talked about. And we talked about those numbers, those statistics, but then the ask for Secretary Azar, and this is true for policy folks really across the board, was let's make this parity permanent. Because until we actually have reimbursement be permanent, these changes be permanent in place, then I don't think this is going to be sticky for the long haul. And I think we also have to have other reform elements, including the ability to really look at how we look at licensure across borders, right? So right now, we've got multiple different ways of handling licensure across state lines, and this can't happen in a progressive United States. So we have to look at things differently if we want the different results to be sticky.
Agree with that. And just building just mental health care, for example, just part of the issue is reimbursement. And why are we decoupling the mind from the body and poorly reimbursing for that? And you could make a strong argument from a population health perspective that it's all starting there. And then, mental health issues, poor sleep issues, deteriorating into lifestyle diseases. And then lo and behold, the health systems kick in, but that's when things are getting expensive. And so if it were reimbursed on the front end and advocating for that, that will be a game changer and will re-trigger how care teams deliver care, and even rethinking medical school, right? It's like, what are elements that need to shift? And just really excited going all the way back to what is that care going to be? I think I was taking an aggressive stance up front around what if you started from scratch? That's really just a thought exercise. But the true blend is, how do we take the best of what we do in care delivery and the world-class clinicians that we have and carry that forward into a new paradigm? And I think that's really thematically, it sounds like where this group is unified.
As we taper out towards the last few minutes, Ashima, I'd love for you to jump in, and then we'll ask Chris and Rasu to close out. Is as you start to think about innovation and the things you're working on at Google, what are you doing with your roadmap, your prioritization, and those kind of things? So you had a roadmap pre-COVID, but your roadmap post-COVID is probably tied to what Sutter and Atrium and guys like Rasu and Chris are asking you. What does that look like today? What are your top items for your roadmap over the next 12 to 18 months? And then what I'd love for Rasu and Chris to do is maybe give advice to those entrepreneurs, innovators outside saying, hey guys, stop giving me this crap. Start thinking about this area, right? So if you guys can think about that while Ashima is telling us what the Google roadmap looks like, that'll be good.
Thank you. I wanted to add one more line on the telehealth advocacy, the two words, and I hear from a lot of provider systems, telehealth, no rollback. I think we all need to create that a Twitter tag and probably have Rasu tweet it. That way kind of sticks. We need to come together as a band and say no rollback. Yes, the reimbursements are good, but now we have a more empowered consumer, and I'm hoping that we all demand as new consumers and some of this will stick. Coming back from our roadmap, I think what has changed is our principle is much more, it was always being helpful about serving, but that empathy in the times of COVID is very heightened. So we are working very closely with the industry, with academia, and especially with our customers, like folks like Rasu and Chris, in understanding what are the pain points. And some pain points are on the innovation. And you had mentioned earlier the cost pressure the industry is in. Like we've had health system have furloughs. So what could we do to be helpful in terms of cost optimization? So that's one bucket. The second is the leading with empathy and empowerment is what tools can we build to be helpful to providers, to the frontline workers. And then AI is much hyped word, but a lot of the response to COVID is in data and in science. What tools can we build and be better forecasting of the hotspot, better forecasting of where the next set of vaccines are needed? We have seen the fragility in the supply chain. So it's many different areas, but three kind of big buckets, and cost optimization, so being of service in terms of how can we lower the total cost of ownership in cloud? Like the business model is completely different. The second is around the empowerment and leading with the empathy from the patient and providers, and then leading the response for data and science and building those helpful tools. We have Cloud Healthcare API, where COVID has underscored the need for interoperability like no other event before, and this will stick on.
Yeah, makes sense. So Rasu, jump in a little bit to maybe advise companies like Google and others.
So Ashima mentioned the word, a trigger word. She said interoperability, and I have to comment on that. I think the advice and the way that we're looking at things at Atrium Health is, I think it's important for us to widen the aperture on interoperability, right? For the longest time, interoperability was all about, hey, let's look at having one EMR system interoperate with another EMR system. And maybe at best, we have claims data coming in from the payer. And wait, wow, that's interoperability. And let's have some FHIR interfaces and APIs and boom, rock and rolling. I think what COVID has shown us is that the walls between healthcare, where it's traditionally resided, which is in medicine, and public health have forever come down, right? And I think it's important for us to understand that we need to broaden the aperture even around interoperability so that we're really bringing in data elements that are well outside of the walls of health systems and medicine in general. It's not just about meds, allergies, immunizations, problems, labs, and maybe claims data. It's also about social determinants data. It's about zip codes. It's about public health data that maybe health systems traditionally weren't in the business of managing. And so working closely with analytics capabilities, cloud capabilities. We're looking at syndromic surveillance. We're looking at sharing data across larger health systems so that we can track the next pandemic, but also would be able to leverage geo-mapping capability, geospatial capabilities to really look at those hotspots and really make an impact in communities that are being underserved. Right, and we saw that even in the Southeast here. We saw that the African American populations and the Latino populations and the communities were not getting the testing resources like the other zip codes were. And we're able to hotspot those and immediately send out our mobile testing units. And as a result of that, we saw the numbers actually stack up against each other, where we saw the same level of testing in all of the zip codes in the areas that we serve. So it's those sorts of innovations where we have to widen the aperture. We have to think of healthcare well beyond the walls of medicine where we've traditionally resided, but then really be innovative about thinking of whole person and whole community care versus just sick care, which is where healthcare has been focused in on for the longest time.
Yeah, so, and Chris, we'll have you take us home here in a second, but Rasu, tell us a little bit about, is there any room for anything other than COVID-related pandemic kind of care? Like there's obviously, you have a huge health system, you must be buying other stuff, you must be working on innovations that are not directly related to COVID. What are those, and what's still alive even beyond COVID?
Oh, absolutely. I think COVID is just the spark that lights up the fire of how we need to think about healthcare transformation, right? So all of the things that I've mentioned, whether it's around the point of care ultrasound or whether it's around the geo-mapping capabilities, that's just a spark. And the fire is really about care transformation overall. FHIR is about leveraging population health and precision medicine, but really saying, all right, how do we focus in on that whole person care versus just managing the specific elements of, say, virtual care or the specific elements of what goes on in the ICUs or these pop-up clinics. It is about looking at that much more holistically.
Yeah, makes sense. So Chris, we'll give you the last word here.
Yeah.
Two things. One is focused on what advice would you give to entrepreneurs and others that want to work on new things? What should they focus on? And what beyond COVID is Sutter still focused on, where things that you're looking from the community for?
Yeah, so I think this is a really amazing time to integrate information, and whether that's Google Cloud or other abilities to do so. Before COVID, it was fires in Northern California. And the example I like to use is, we knew the Tubbs fire was burning out of control. We knew the wind had just shifted. We knew who our asthmatic patients are. We knew who needed a refill. And what did we do? Nothing. We waited, because weather data is not incorporated with the healthcare record. Yep. And so that ability to link that information has never been simpler. It's still complicated, but it's exponentially simpler than it was before. And so I think there's a big opportunity for startups to just know that they sit in an ecosystem, and for cloud-based operators to know that you're the ultimate consolidator of the patient 360 to make really informed decisions. And so, diabetes management, for example, right now, a patient could go to Livongo, they could go to Amada, they could go to Virta, they could, and so what happens is it gets fragmented, and then unfortunately, the patient themselves loses track. So they may have a mental health issue, diabetes, and heart disease, and they're literally broken across a bunch of different entities and startups that are trying with good reason to help them out, but they're not consolidated back again into a central plan and a central unit. The last thing I would say to close this out is, don't be afraid to start with the underserved. I think these are where some of the greatest problems are. And I don't quite understand often when the startups don't see business opportunity there. So an example I would use here is there was a single patient in the state of California on Medi-Cal that cost the state $30 million. And ultimately, that was where all the taxpayers that paid all of those bills, from a patient coming in and out of the ER, not well maintained, coming in and out of different systems. And so I'm encouraged by organizations and startups like CityBlock out of Google that are starting with that population, saying this is actually the beginning. This isn't the group that the learnings from the high end, we'll figure that out, and then we'll go to the rural communities. Like, no, start with the rural communities, start with the underserved communities. These are where some of the greatest breakthroughs are, and then spiral it to different groups where those start centers are. And so I'd like to see more starts in the underserved communities, not just prompted by what we're seeing today, which has really amplified that, but those opportunities existed before all this. And if nothing else, they're good venture-backed opportunities to go after those. They're not just because people are trying to do the right thing. They're because if we solve this, we'll crack the code on some of the economics and why it costs the nation so much to run these. So really excited about what cloud brings, what the startup community can bring. And I think the proxies, like big traditional healthcare systems have all the patients, they've got the physicians. Startups have the agility, the ability to pivot their models, they're fast moving, and they're really complementary to each other, and excited about what this era will bring. And big collaborators like Google and others to really advance that by saying what you need is a platform to unify some of this thinking.
I wanted to just thank our panelists here, Ashma from Google, Atrium's Rasu, and Chris from Sutter. Appreciate you guys spending the time here.